Good evening, everyone. Sorry, I was speaking to myself there for a moment, forgot to unmute. Thank you for joining us this evening. It's a very cold evening in Potch, so I hope you have coffee and Milo and something to eat. But I promise you, this is going to be much more entertaining than watching a Netflix movie. So you're in a good space tonight. First of all, I want to give a shout out to Pfizer for sponsoring this event. So this is one of 11 talks that will be done in the series that's sponsored by Pfizer. It will be every week in the same time slot. So it's every Wednesday at 6:30, except for during the school holidays. So we will have 2 talks now, then the school holiday, and then we'll continue with the other 9 talks after that. We will send the invites, share on LinkedIn, share on Facebook, and share everywhere for you to follow. Then just a few technical details. So I understand that some people registered that didn't have the option to enter their HPCSA number. So if you want CPD points from this and you didn't have the option to enter your CPD or your HPCSA number, please go to our website, the NMP National Metabolomics Platform website, go to the contact form and just send us a message there to say that you attended and that you want your CPD points. Then we will send that to you. I'm sorry about that glitch. Then, yes, okay. So tonight you are privileged to be in the same room, so to speak, as the #1 expert in newborn screening in South Africa, Ms. Brenda Klopper. That's why I'm saying you will have a much better evening than if you were in front of Netflix. Brenda has a very, very long CV, so I'm just going to give a very quick snippets from the CV. Let me just find it. Okay, so Brenda received her MSc degree in biotechnology in 1994 from the Northwest University. She then started her career in Pretoria at the Agricultural Research Council, studying African horse sickness virus. After then, she moved to Potchefstroom, where she also worked at the ARC, but at the Summer Grain Center. Brenda then transitioned to the metabolic laboratory at the Potch campus of the Northwest University. At that time, it was known as PLIM, and it was known as the PICA. And we are all very glad that Brenda made that move from the ARC. Brenda then this I'm going to read in full. So in the next stage of her career was at the newborn screening lab at the Northwest University campus. She was the manager of the NBS lab, responsible for planning, organizing, and overseeing the lab's operations. She developed and implemented new methods to enhance the newborn screening panel of tests, ensuring more accurate and comprehensive screening for newborns. Her role also involved setting up a lab information management systems, or LIMS systems, and automated processing using advanced technology such as Hamilton robotics systems. As part of the diagnostic interpretation team currently at the CHM, Brenda is contributing to the critical analysis and interpretation of newborn screening results. More than that, she's also helping to do the diagnostics of the interpretation of the diagnostic results, not just newborn screening. Brenda is also involved in the method development and validation. She is the anchor for the pre and post analytical work of newborn screening, collaborating and discussing results with doctors and parents. And also Brenda has a strong passion for the marketing and promotion of newborn screening in South Africa and also in Africa and the world. That wasn't in your CV, Brenda, I added that. Brenda is a member of the Health Professions Council of South Africa. She is HPCSA registered as a medical scientist, and her professional journey is marked by a passion for newborn screening. You're in very good company this evening. Please enjoy the talk. So after this presentation, you will have opportunity to ask some questions in the Q&A portal. you'll see at the bottom of your screen, there's a Q&A session there where you can add your questions and Brenda will answer the questions live. There's also a chat box to enter your questions in the chat box. You're also welcome to put up your hand. So you have an option to put up your hand if you want to ask your question live. So if you put up your hand, I will unmute you. So there's a raise hand option there. I will unmute you and then you can answer or ask your question live. Thank you very much, Brenda. I see you still at the office, working very late this evening.
Yeah.
We are looking forward to this presentation. Enjoy it. Thank you.
Thank you so much, Ilse, for that kind introduction. And thank you, everybody, and good evening to everybody that's joining the talk about newborn screening tonight. I think I've seen on the list of the people joining that we also have other people from Africa joining. Welcome to the Maputo, the Mozambique guys, the Botswana guys. And if I missed out on any other Africa continent people also joining in this talk, welcome to you as well. So I'm glad that you can join us tonight. So yeah,
Brenda,
thank you for,
sorry.
yes.
There's already in the chat box saying, I'm Dinah from Nairobi, Kenya. So you have someone from
Okay.
Botswana,
Okay.
Mozambique, and Kenya, yeah.
Okay, welcome, Kenya. If there's anybody else, put up your hand so that we can see who's joining us. So yes, you're more than welcome, and thank you for joining us, and thank you for joining us tonight in the journey about newborn screening. We're going to have a look at the past, the present, and then we are also going to take a sneak peek into the future of newborn screening. So the outline of my talk tonight is I'm going to quickly introduce the National Metabolomics platform, and then we're going to have a look at newborn screening. We're going to focus on, I think, the questions that's normally on everybody's mind. That would be, what is newborn screening, why, when, who, and if not. So we're going to touch a lot. We're going to look at the past, the present, and the future prospects as well. Okay, so I think Elna also showed the slide last week. So we're part of the National Metabolomics platform. So just a little bit more about that. The National Metabolomics platform has been working to develop metabolomics capabilities within South Africa for the past 10 years and has become a center of excellence in the service offerings. At the NMP, we use various sophisticated techniques, instrumentation, diagnostic processes to identify various inborn errors of metabolism. So we have the different service laboratories, which is firstly the diagnostic lab, the newborn screening lab, the biobank that Elna previously presented on, and then we also have the project analysis side. So for the purpose of this talk, I'm mainly going to concentrate then on newborn screening. So like I said, we're going to answer all your questions that you have. So newborn screening has been undergoing a shift from corrective medicine, and it's now all about preventative medicine. Newborn screening is therefore this important part of preventative medicine. And like I said, all these questions are on your minds. We're going to touch on all of them throughout the talk. So the first one, what is newborn screening? So newborn screening is a health program that involves testing for newborn babies for certain genetic, metabolic, and congenital disorders shortly after birth. So the goal is catch them early. That's our main focus with newborn screening. We want to identify babies with the potential life-threatening condition. We want to provide early treatment and intervention to prevent or reduce long-term health problems, and we want to improve the outcome and quality of these affected babies. So I'm just quickly going to journey into inborn errors of metabolism. I'm not going to say a lot about that, but I just want to quickly show you there's quite a lot of disorders. More than 600 metabolic disorders been described up to date. So you can think, if we talk about 600 metabolic disorders, how many metabolites are associated with the specific metabolic disorders, and then in the end, how many metabolites do you need to look at? So in the newborn screening, we look at amino acids, acylcarnitines, the organic acid disorders, fatty acid disorders, and then we also have the two enzymes that we do at the moment, the biotinidase and then the GALT enzyme for the galactosemia. So first, we need to understand the genetics of these metabolic disorders. They are autosomal recessive, so it's all about watching your genes. And also very important, most of the parents normally tell me, no, they don't have a family history. They don't have to be a family history. A family can have 2 or 3 normal children, and only with the 4th one, you'll see this metabolic disorder presenting. So it's very important to remember they don't have to be family history. Okay, so then the next question would be, why do we do newborn screening? So here, early detection is the key, and prompt and correct newborn screening practices can save the life of a baby. With early intervention and treatment, even babies with serious diseases can live a long and happy life. So like I said in the previous slide, we need to catch them early to make a difference in that baby's life. That's why newborn screening is so important to us. So if we quickly jump back into the past, how did it all start? And we're going to start with looking at the birth of newborn screening. So the birth of newborn screening, Robert Guthrie was the father of newborn screening. The history of newborn screening therefore began with the discovery of phenylketonuria by Robert Guthrie in the early 1960s. Dr. Guthrie developed a simple bacterial inhibition assay known as the Guthrie test, which could detect elevated levels of phenylalanine in a drop of blood from a newborn. The test, introduced in 1963, became the first mass screening test for genetic disorders. So that's where it all started. So if you look at the different milestones in newborn screening, so like I said, the first test was the bacterial inhibition test for PKU. So screening in those days were just limited to 1 or 2 disorders, which PKU was the first one that they was in the panel. And then, like I said, that was just for a bacterial inhibition assay, and it was just limited to certain countries. Then thereafter, during the 1970s and 1980s, additional disorders were included in newborn screening panels, such as congenital hypothyroidism, galactosemia, and sickle cell disease. The criteria for adding new disorders typically included in the newborn screening because of the availability of reliable screening tests, the severity of the disorder, and the existence of effective treatment was also very important in those days. So this brings us to the next milestone. So in the 1960s to 1990s, and this is continued for 2 decades, there was, like I said, those congenital hypothyroidism, sickle cell disease, congenital adrenal hyperplasia, cystic fibrosis, and some other metabolic disorders was included in the newborn screening panels. So in 2001, there was a fast technology was introduced. The introduction of tandem mass spectrometry in the early 2001s revolutionized newborn screening by allowing for the simultaneous detection of multiple metabolic disorders from one single blood sample. The technology greatly expanded the number of conditions that could be screened for. So yeah, this really created an explosion in newborn screening. And at the moment, we can do 22 analyze, 24 disorders in a run of 2 minutes. That's why we're saying this really created an explosion in newborn screening, the disorders added to the panel. Okay, so in the past, it was very difficult to diagnose these babies early, and that was a problem because the doctors would normally just see them after the clinical picture has presented. And in the present, we have now fast and reliable diagnostic tests, and it's more part of the preventative medicine. So this can really make a difference in a baby's life these days. So in the past, it normally was too late. Okay, so the next milestones in newborn screening was since 20,000 until the present. There was expanded newborn screening panels for up to 50 disorders. I know in America they are screening for 55 disorders at the moment, even including molecular testing as well. So there's a lot of automated laboratory testing and data analysis was implemented, and then so there was a increase in the different countries screening for more than just, say, maybe PKU or congenital hyperthyroidism because of these expanded panels and the explosion in technology. So in South Africa, if we look at the criteria for newborn screening, there was an article published from Wilson and Ljunggren, which this article showed criteria, and I'm just going to highlight the most important. So the conditions should be an important health problem. Effective treatment should be available, and there should be a suitable test or examination for that, and then simple and inexpensive. The cost is then also really important. So if we first go to the conditions that we screen for in newborn screening, we need to look at the different disorders. So you need to do a needs assessment to identify potential disorders that would be possible considerations for the newborn screening. And this can involve reviewing medical literature, consulting with experts, and analyzing health data to determine the prevalence and severity of the specific disorders in the target population. So in America, they also recommended a uniform screening panel, which is indicated on the screen now. Sorry, it's really very small, but I just wanted to show you that they implemented a primary panel and then also a secondary panel, which I'll show you. But in South Africa, we mainly do the primary conditions that was suggested in this from the HRSA. So I just want to show you these different diseases. So this is the organic acid disorders, the fatty acid disorders, the amino acid disorders is listed here. And then also the endocrine, the other disorders like the congenital adrenal hyperplasia, congenital hypothyroidism, and then also included in the primary panel in America at the moment is also the hemoglobinopathies, which we don't do, but we really had quite a lot of interest from the Africa, from Mozambique, Botswana, and Kenya to maybe include this also in the primary panel, but for the moment we don't have it available. And then we also do in this primary panel 2 enzymes, the galactosemia and the biotinidase disorder. Okay, this is just the secondary conditions. We're not there yet. We're busy expanding the panel as well, but we also need to keep in mind the treatment availability as well as the prevalence for South Africa, or for Africa if the other countries is also involved in the screening. Okay, so an article was published early this year with Dr. Helen Malherbe, She showed in this article newborn screening in South Africa, the past, present, and plans for the future as well. And from this article, you can see from 1998 to 2023, the most prevalent disorders for South Africa was congenital hyperthyroidism, biotinidase, propionic acidemia, galactosemia, and cystic fibrosis. So the prevalence in South Africa or in Africa is quite different from what's prevalent in America. I know the American group is more the MCAT and the PKUs. They really have a different prevalence in their country. But we are concentrating what's prevalent for South Africa at the moment. So if we look at the newborn screening panel of tests, you can also get this on the website, sorry. There you see the list of all the different amino acid disorders, the organic acid disorders, as well as the fatty acid oxidation disorders, and then the other disorders that we screen for at the moment. At the moment, in one blood test, we screen for 22 disorders. So the next thing would be to look at the tests. So you need to have a screening test that are scientifically validated and reliable with low false positive and false negative rates. The feasibility of the test must also be investigated, and the test must also be very cost effective to the healthcare system. And this also includes considerations relating to the laboratory testing, the equipment, the staff training, and the follow-up care of these patients. So the technology platforms for South Africa that we have available is the immunoassays, where we screen for congenital hyperthyroidism, congenital adrenal hyperplasia, and cystic fibrosis. Then we also have the two enzymes, the GALT enzyme and the biotinidase enzyme that we do the activities on the blood card. And then in the MS, I will show you just now 2 slides which include all the different amino acids, fatty acid oxidation disorders, as well as the organic acidemias that we screen for. So firstly, if we look at the amino acids disorders over here, you can see it's the list of the disorders with the incidence, with the treatment, and then the consequences. So I'm just going to concentrate on one of them. So PKU, the incidence is 1 in 10,000. It's just altering the diet. And if not, those children can have mental retardation problems. So associated with a specific metabolic disorder, you have major markers associated with that. So in the case of PKU, you would have elevated phenylalanine, low tyrosine, and the ratio for the phenylalanine tyrosine would be abnormal. So then if we go to the next slide, this one shows the organic acid disorders as well as the fatty acid oxidation disorders that we screen for. I'm just also again going to highlight just one of them. Propionic acidemia is quite prevalent also in South Africa, and incidence is 1 in 50,000. And the treatment is just to alter the diet, and if not, those children can have seizures, acidosis, can go into comas, and even premature death. So again, how important newborn screening is for a child. I know with propionic acidemia as well, a child can go into a coma at day 7 to 10. They can go into comas. Fatty acid oxidation disorders, I'm just going to also touch on one of them. It is like the disorder is the MCAD, incidence 1 in 10,000. Also alter the diet and avoid fasting here. And the consequences is normally the blood sugar of that baby normally is very low, and then this baby goes over to the fatty acids to produce energy for the body. And if they can't break down the medium chains, and then they can go into a coma and die if they're not treated early enough. Okay, yeah. Then the next slide is we need to consider the treatment as well. You need to have effective treatment available, and it must be also acceptable. And it is crucial to ensure that effective treatments or interventions are available for the disorders being considered. Okay, just the next one on the different conditions. Over here you can see the different conditions. I've just highlighted some of them. And then you can see the treatment, like in the case for PKUs, a diet treatment, they need to go onto a special milk formula. And the care complexity is very high. So this is over here you can see also the consideration. You need to look at things that are quite the cost for and the care complexity is very low. So in the case of congenital hypothyroidism, it's altroxin, the treatment, and the cost to treat those babies is quite low. That's why the cost and the treatment is also a very important consideration when you decide on which disorders to screen for. So the next one would be to look at the cost. So the cost benefit analysis is also necessary. The screening process must be practical, cost effective for the healthcare system. Consider the economic impact of screening versus the potential healthcare cost savings and improved outcomes. So over here, I also showed congenital hypothyroidism. The cost for detection is very low. Confirmation test is low. The treatment is low. So that's why it's included also in the panel of tests. The same also with biotinidase deficiency, galactosemia, and then we showed here PKU, high prevalence, but severe consequences that you can save the baby from. Okay. So just also the same table with the different conditions. And over here you can see if, maybe example is galactosemia. So the cost of care is very low. Like I said, the cost of care for PKU is very high. And then biotinidase, just to mention a few of them, is also the cost is very low. When you also consider disorders for the newborn screening, there's also ethical and legal considerations. You also need to have public and stakeholder engagement, and you need to involve the community and the parents' input, and there's also legal and regulatory compliance. In the next slide, we're going to quickly touch on the 7 components of newborn screening, which would be education, screening, diagnosis, conveying, follow-up, management, and evaluation. These are all very important. The education of the parents, the public, and the professionals. The screening involves the collection and the testing and storage, the diagnosis, interpretation of results, and the reporting. And conveying to the doctors, how would you tell the doctors, how would you tell the parents, the counseling of the parents, the follow-ups, how do you handle the repeat test of positive cases, and how do you confirm? And the management then would be the treatment, the monitoring, and the long-term outcome. So the evaluation, you also need to evaluate your program, look at your cost effectiveness. You need to look also at the quality assurance and the outcomes from your program. So then we go to the ABC of newborn screening. So the first one for the A would be to ask a doctor or to ask somebody about newborn screening. B would be to be proactive, and C would be to come and visit our website. So you can log onto the website, the National Metabolomics website. You can, or you can scan the QR code that we have available now on our new pamphlets. You can just scan that, and that will take you to the website. We just have a short video. In the next one, I just want to demonstrate how Vostell is working. So let me just play this. Okay, here's pregnant mother, she sees the pamphlet with the doctor. She can go ahead and scan the QR code if she needs more information or if she wants to order the test. And over here, you would see the communication coming through from the system. So it can be a parent asking question. It can be a doctor asking question. Everybody can go onto this, can log on or scan the QR code, and they can ask a specific question, and then we'll have answers. So this is still in the developing phases. So there's still a lot of things we want to do with this to make the doctor's life easy. He can just log in. If he quickly wants to see what the panel of tests is, he can just quickly scan the QR code, go onto the website, and he can see, oh, Vostal would also answer that question. If he types in panel of tests, we want this also to reply to him and tell him, the doctor, exactly what's included. So for doctors, for parents, for everybody who's interested. So we also have the biobank, and the UNWE is also going to be available on the site for anybody. So this is still in developmental phases. Okay, so I just want to go to the next slide, just to show you from the mother's phone. She asked, she said hi, and then she asked about newborn screening, and then she ordered the test, and then all the necessary information that the parent needs, how to do the newborn screening, where to go. They provide also the necessary information, and when we then arrange with the different pathology groups to do the collection whenever the baby's due date is. So closer also to the due dates, we also want to just send out a WhatsApp to the mother again, and just reminding her to keep in mind that we need all the information and where the baby is going to be born, so that we can arrange for the collection. Okay, so this is already maybe moving into the future. So we are making use of AI as well to answer different questions to the doctors and stuff. The parents can also go onto the website if they scan the QR code. If they want to put a query there and do all the information on the website, they can also do that. But Vostal is going to really make it so easy for the parents to order the test and to get the test done in the end. And we also want to, in the end, communicate results also through this. But like I said, it's still in developmental phases, so there's still a lot to do there. Okay, so on the website, there's also information about when to do the test. So after 24 hours, so we're testing the baby's metabolism. So the baby must have had feedings, and the baby will then normally be in a catabolic state for us to see the fatty acid oxidation disorders, and the baby will then be in a post-TSH surge as well. And how to do it is all explained on the website, but it's normally just a heel prick, and then the blood is spotted onto a blood card, and the card is sent to the laboratory. It goes through different processes, and then in the end, the data analysis and the interpretation. We also make use of the Mayo Clinic, the CLEAR tool. So this also assists us in the interpretation of the results. I just want to quickly show some of the features of the CLEAR application that we use from Mayo. So you can upload the data for all the patients and then run it in the tool runner, and in the tool runner, it will show you informative markers, and then it will show you a whole batch as well. So we really make use of this in the data analysis and the interpretation. It's making our lives quite easy. So with the Clear tool, we're already moving into the future, so we can do predictive analytics, algorithms that you can look in this data. You can search for that in this data. It uses different ratios of different analytes. It's also automated data interpretation model that helps us to interpret complex newborn screening data, and also pattern recognition. So all this program helps us to identify patterns in the newborn screening data and to help with the diagnosis so that we can start treating the baby quite easily. So on the Clear application tool, we have the single condition. Over here, you can see this was a case of PKU. To the bottom here, you can see the different analytes. The blue ones is the informative markers, the gray is non-informative markers, and then you can see the black spots indicate this specific patient's value. So in this case, you can see that the phenylalanine is really high, and the ratio of phenylalanine and the tyrosine. So this helps us really to look at a lot of data and quickly make a diagnosis. Then we also have in this tool, we have an all conditions tool, which you run the sample against all the conditions included in the primary panel. And then we also have the application of a dual scatter plot, where you can plot, say, maybe you want to distinguish between a PKU or a biopterin disorder. You can do a dual scatter with the two. And in this case, that red spot is this patient, and you can clearly see this is a PKU. So this really helps us a lot with interpretation. So when the results go out to the parents and the doctors, you can normally have a normal result. So when we finalize on the report from our LIMS system, there will be a SMS directly sent to the parents telling them that everything is normal. And then as soon as I also finalize on the report is emailed to the referring doctor to see the results as well. In the case of when we have abnormal results, so this is a little bit more complicated. So we need to phone the doctor, or maybe in the future we want to SMS the doctor, or just make use of voicemail to inform the doctor this baby's results slightly elevated. So maybe IRT, we need to follow up. And then we need to inform the parents. Then we want to also do this for the doctors. They sometimes have preferences that we must handle just a normal repeat card. But when there is already like diagnostic testings that's going to be asked for, like urine and serum for, say, maybe organic acids and acylcarnitines, then we need to inform the doctor about this. So as soon as after I've informed everybody, the report is finalized, and the email is sent to the referring doctor. The SMS go out to the parents telling them that you will be contacted shortly. And then from there on, we have different WhatsApp messages that goes out to the parents. So ANSI is normally handling this communication to the parents as well. So we have a first WhatsApp going out, giving the parents all the information, where to go, which laboratory to use, what the test code would be, so they can just take their phone, show the referring laboratory what tests need to be done, and then they can do the collection. If they don't, after 3 days, if we see the sample is not received yet, then ANSA will send out the next email again on 3 days, and on 5 days, just reminding them to please remember to do a repeat card. We also have fact sheets available for parents. So maybe a diagnosis is made, then so maybe in this case like a PKU, we would have all the questions on there that the parents need to know. What is PKU? The basic stuff. Because if there's a positive case, they're normally quite overwhelmed, and we need to convey the information as clear as possible to them so that they completely understand. We don't want to get patients that's stressed out. So we need to keep them calm and explain everything quite clearly to them. And also we have communication that we can send to the doctors as well. There is the ACMG, the act sheets and algorithms. So in the case of a PKU, you would have elevated phenylalanine. The doctor would see here what's the differential diagnosis, the conditions descriptions, how to go about further to work up this patient, and the clinical considerations as well. And to decide as well the algorithms. So what the doctor needs to do, he needs to then refer a plasma for amino acids, and then he can just continue in the flow chart how to make the final diagnosis. But we're also available to help assist in any diagnostic testing further on. So then if we move into the future, so let's see what the future holds for us in newborn screening. So in the future, from 2020 and beyond, there are already talks about next generation sequencing and whole genome sequencing. So expanded screening processes for more genetic disorders, making use a lot of with the artificial intelligence and machine learning applications. And then we've already started with some of the automation processes over here as well. We have the Pantera puncher, which can punch for all the different tests at once. Here to the bottom, you can see it immediately punch for all the different tests. So this already saves a lot of time as well on our workflow in the laboratory. And then we also implemented the Hamilton automated liquid handler and sample preparation. We have automated workflow on the Hamilton, where you would have centrifuges, you would have evaporators. It's transferring the sample, it's drying, everything is done on the Hamilton itself, saving us a lot of time. So we have a cost effectiveness, improved quality of results, and then okay, yeah, sorry. I think that's it for the Hamilton. So just zoom into everything that's on the Hamilton stick. So all the sample prep is done on the deck, and then we have implemented a new interface directly to a SciEx. So the sample prep and the injection that goes directly. So you can, this is a completely automated procedure which we are busy implementing in the laboratory as well. So then if we look at artificial intelligence, it's quite interesting to see what's happening overseas as well, the predictive analytics, the algorithms to help in the data analysis, the automated data interpretations, the pattern recognitions, the clinical decision support, also the AI-powered tools that they use, the parent support as well. Just to mention the future of newborn screening, if, in short. And then there's also the AI chatbot bots, where they can also give emotional support to parents, 24/7 availability, there's personalized guidance. The chatbots can help to advise what to do. The follow-up testing, also virtual assistants to ensure that the parents also receive necessary follow-up testing, and so forth. I'm not even going to touch on all of them. So yeah, that's the future for newborn screening. And the last slide, I just want to show this again. These two babies, the one was screened and the one was not screened. So the one to the left-hand side, you can see what his life would look like in comparison to a child that wasn't screened. Same disorder, this one is on treatment, doing well. Look at the difference in the two babies' lives. So that's why I just want to tell you again how important newborn screening is. We need to save babies' lives, and let us create the possibility for every baby to be screened to secure a better life. So I just lastly want to show you, we are the National Metabolomics platform team, and we rare diseases warriors. Here's just some of the photos of the personnel working here. And just another last quote from Rodney Howell. I feel that it would be unwise, indeed unethical, to deny life-saving and simple treatments to infants when simple and accurate testings are currently available. Okay, and that's it. Any questions? Thank you for the opportunity to speak to everybody regarding newborn screening.
Thank you very much, Brenda. There's a question from an anonymous attendee asking, how many newborn screens does your center handle per year?
We do about, at the moment, 500 in a month. So times 12, yeah. Yeah, it's 6,000, yeah. But that's just in the private sector, and we really want to get the government also on board, and we're working with the medical aids as well. There's a lot of marketing stuff going on. I maybe can mention Sarah Leah, the marketing company as well, that helps a lot. We're going to do a lot of marketing in the hospitals. And to get the medical aids on board, we really want to get South Africa on the go with newborn screening, because it's so important and you can make a difference in that baby's life. Yeah.
There's another question that's asking about HPCSA numbers. So in the initial, when the talk started, I mentioned that I think people joined after I said this. We had a glitch in the registration system. So if you didn't have the option to add your HPCSA number, please send us an email, or you can go to the website that's Brenda's been showing, the National Metabolomics platform. There's a contact form on that website, and you can just fill in that contact form and say that you attended, and this is your CPD, this is your HPCSA number, and we will then send you the CPD points, or you can just send an email to plim@nwu.ac.za. Okay. The easiest, I think, to remember is just to go to the website, contact form. We have a question from Dr. Tumelu Sategi. Thank you for an inspiring presentation. It will be great to have newborn screening coverage in the public sector. Yes. The main challenge we face in the public sector is the early discharge of our babies. Are feasibility studies being conducted on newborn screening few hours after birth?
Yeah, at the moment, it's 24 hours, but we're working at looking at 6 hours. So that's still a study that's ongoing. So we can't move there yet. We need to investigate this further. But we are trying to see if we can move to 6 hours after birth.
Okay, then there's a comment from Ansi Mini saying, thank you for a very informative presentation on newborn screening, Brenda.
Thank you.
Then there's a question for from Drew MacArthur, asking, how expensive is the screening? Is it feasible for government to implement for all infants? Is there a high-risk category for screening?
Okay, so the first question would be the cost. So the cost is ranging from 1,700 to 1,900. That's also available on the website. It depends which PAF group you use. They normally charge a collection fee. So if you make use of PAF or Lonza, just maybe check with him the collection fee cost. But it normally ranges from 1,700 to 1,900. And it's very important to screen the babies. So if you look at the cost of a child that needs to be institutionalized because of mental problems, or the parents being taken out of their economics, the parent can't work because they need to stay at home. So that's also really making the cost quite expensive on the government. So to screen is a small price to pay.
I just want to add there, so we've had these discussions a lot, and we are currently, as Brenda said, screening for 22 different disorders. We have had discussions of screening for only 1 or 2 of the more prominent disorders, such as congenital hypothyroidism. If you do only 1 test and you test for only 1 of these, I know that to test the thyroid hormone is about 100 Rand or less. So Drew, to answer that question is, I think you should look at if you want to implement this nationwide and have it paid from the government, it would be better to start off with 1 or 2 diseases or 1 or 2 tests that perhaps doesn't involve liquid chromatography, mass spectrometry, or these expensive types of technologies, but only go for the less expensive ones and the ones that's more prominent. And I think if there's any researchers in the audience, we are really in need of prevalence studies in South Africa, because we have no idea what the real prevalence of these disorders is in South Africa, because we do not screen enough babies. So we can't say that hypothyroidism is a 1 in 10,000. It might be even much higher than that because we don't screen enough. So if there's anyone who wants to do the project, wants to do research on prevalence studies, please contact us. Then Sergio, our friend, Sergio from Mozambique, saying, Brenda, congratulations for a very nice presentation. Do you have any statistics of the health impact of introducing newborn screening in South Africa?
We have that article just now on the prevalence. So maybe I can send him that referral to that article. And there was also now a follow-up from Dr. Helene Malaber. I think I will send him both articles, then he can maybe just have a look at that. Yeah.
So I think how I understand the question is, if these babies that we diagnosed through newborn screening were not diagnosed, what would the impact have been financially?
Yeah.
You know, if all of these babies that we diagnosed in screening, you know, had to go to through different diagnostic routes and they had a significantly longer diagnostic odyssey, had to go to hospitals and, you know, institutions, wheelchairs, all of that. I mean, what would that have cost in terms of finance?
Yeah, I don't think for South Africa, I definitely did see an article from the American groups, which has showed that. Yeah, but not for South Africa at the moment. We don't have that statistics yet.
Okay. So Dinah Mwangi from Kenya is saying excellent. And Sylvia Morgan also says excellent. Thank you for the talk. We have another question here from Sipho Ranghani, Yani. Sorry, I'm falling over myself. Ranghaya. I managed to grasp use of MS for NBS, and I am also interested to know how any example of molecular technique testing can be used. Did I get the question?
On the MS side,
So,
no, it's
yes.
molecular testing for the genetic. Sorry, sorry, I missed something there.
I'm
Sound
going
went off
to
a little.
unmute you, Sipo, if
Yeah.
that's fine, because I don't think we understand your question very well. Elna, can you please unmute Sipo Ranghai? I see I don't have any rights to do that. In the meanwhile, there's another question, and I think this question should go out to the audience and not necessarily to Brenda. So the question is from Chris Foster. Professor Chris Foster, our director, is asking the audience, what can we do to get newborn screening going in Africa? What should we do, and how can we assist? How can we help to get that done? And this is open to the audience, so you're welcome to answer in the chat box or just put up your hand if you want to answer live. Okay, Sipo, you are now able to speak. There you go.
Yes, my name is Sipo Hangai.
Ranghani. Okay.
Yes, yes. I think the presenter mentioned that they also use the mass spectrometry, for NPS screening, but she mentioned that they also use the molecular testing, but I didn't get the examples of what techniques or method they're using on a molecular perspective.
Okay, yes. For South Africa, we don't have molecular testing at the moment, but I know in America on their panel, they have SMA is included on their panel of testing. But
Yes,
we
thank you
don't
so
have
much.
any, at the moment,
Thank you so much. I appreciate it.
Thank you. Thank you for the
Thank
question.
you.
Philip Snyman, yes, 100%. Philip says you need sponsors with deep pockets. So yes, agree. We have a few options for sponsors for research projects. We don't have enough hands. So if anyone wants to, jump on this bandwagon as researchers, please contact us. We also have a biobank. We can provide you with very precious samples from patients with rare diseases for research purposes. So if you're a researcher and you want to work with us, please also contact us. We always love new collaborators. So I just wanted to quickly also mention something. Brenda, sorry. Let me just see, there's another. Okay. So I wanted to say that if you go to the website on newborns and you go to the services that we have, and then there's a newborn screening section. If you go to the very bottom of that page, you will be able to actually download the QR codes for the WhatsApp and the QR code for the website. You can also download the information packages, the poster and the pamphlet. And we specifically did this for people working in hospitals, people seeing patients, midwives, doctors, nurses, so that you can provide this to your patients and to your new mothers and fathers via WhatsApp or in any means that you can. So you can provide this, you can download it, it's for free. If you want pamphlets for your own practice and you want it to be printed, you can just also send us a message on the website, and we can send you the printed documents to keep in your practice. Or and this is even, it's not just important for gynecologists and pediatricians, but also nurses, midwives, anyone doing breastfeeding clinics or prenatal classes. You're welcome to contact us, and we will send you some information pamphlets that you can have there. Then the other thing is just, so Worstel is a program that we use from our side. So I just want to clarify that you are not, as a doctor or as a client or as a mother, you don't ever have to do anything with Worstel. Worstel is what we use to provide as much information as we can through WhatsApp. So you will only receive what Brenda showed in that second picture is you will receive WhatsApp messages, automated WhatsApp messages with all the information that you need. So don't be scared that you now need to go and learn a new program. And then my last comment, I see there's a lot of new questions, Brenda. My last question is that I want to say, thank you very much for Mrs. Vitomi Mahumani, the actor in the video of the pregnant mother. Please don't go to Hollywood. We need you in the lab.
Yeah.
Thank you for participating in that video. It was brilliant. So Vitomi is an employee at the NMP, and she volunteered to be in the video.
I think we also need to thank Malushka and Mareike. They were also involved in the putting all the videos together. So yeah, we have not just analysts here, we have high-tech people that can help with videos as well.
The young ones, Brenda.
Yeah, the young ones.
So Dinah is asking, what can we do to increase newborn screening and to provide access to information for the public and for mothers? So this is what I mentioned is from your side. You can go to the website, you can download the QR codes. They can scan the QR codes to go to the website or to add us as a contact on WhatsApp. They can get almost all information that they need through those channels. The WhatsApp is nice because you can physically go and ask the question that you want the answer for. You can also download the pamphlets, but then I also want to say that if you feel that you want us to go and give training or provide training in the form of a webinar at your practice for your students, for mothers at a clinic, wherever, you can also contact us. So we are very open and willing to go and provide training in a hospital or wherever you need us to provide training. But the quickest route, I think, is to go to the website, go to WhatsApp, and get the information there. I hope that helps. But Dinah, please contact us. We would really want to speak to you further. Then JC David is saying, have a baby. I assume I have a baby with a possible infantile spasms. Is it possible to do your newborn screening test to rule out metabolic disorders in this situation? The baby is already 7 months old, or must we send the frozen urine, etc., as usual?
Okay.
You want to answer that, Brenda?
Yes, I can answer that. We do have reference ranges for up to a year on our system. So the preferable window for newborn screening is 1 to 7 days. We prefer that because the fatty acid oxidation disorders you are going to miss. So that's why we would normally say in the comment, if this is an older baby, we would say it will influence the diagnostic accuracy because this baby is older, meaning that we could miss the fatty acid oxidation disorders. But say maybe if it's something else, that's part of the primary panel that we're testing, yes, we can definitely screen quickly to give you an answer, maybe for the ones we screen for. Say yes or no on those,
Even if the baby is already 7 months old?
Yes, but like I said, not for the fatty acid oxidation disorders,
Thank you very much, Chris. Chris has just sent me a whole essay to read, but I've got to read it. So Prof. Chris Foster is saying, inherited metabolic diseases may be the underlying cause of up to 5% of patients with infantile spasms, although other suggestive clinical features are often present. Infantile spasms may be the first clinical finding. As a subgroup, these patients are important to recognize, seeing that some of the inborn metabolic diseases will be treatable or partially treatable. Phenylketonuria, non-ketotic hyperglycemia, Menkes disease, thank you, Chris. Pyridoxine-responsive epilepsy, methylmalonic aciduria, and pyruvate dehydrogenase deficiency are more frequently associated with infantile spasms. Several other amino acid organic acidemias, fatty acid oxidation disorders, mitochondrial disorders, disorders of disturbed glucose and insulin metabolism, biotinidase deficiency, peroxisomal disorders, and several lysosomal storage diseases might also be present. Additional investigation should be guided by the clinical presentation, meticulous evaluation for neurological, dysmorphic, dermatological, ophthalmological, and auditory abnormalities may aid in the test selected. I think, JC, you can maybe send the clinical presentation to us also, and we can then guide you into which tests we think that you can order to do from the diagnostic panel as well. Thank you, Chris. You're saying well done. I think that was well done for an Afrikaans person this time of night. Okay, so we still haven't answered Chris's question on what should we do to get newborn screening going in Africa. I think if you are from Africa, and we haven't spoken to you yet, please reach out to us. Please send us a message in the contact form, and we can maybe have a discussion via online Zoom meeting or something like that, just to get your feedback. So we are really adamant to get newborn screening out into Africa, and we are willing to assist wherever we can. Okay, so Alna just pasted that entire long answer in the webinar chat if you wanted to read it again. Okay, I think that's all questions. If there's no more questions, I don't see any other questions. I don't see any hands up. Sorry, there's another question in the chat room, I see. In which lab can we send samples for genetic disorders, for example, polymerase gamma poly disorders?
Sorry, maybe Chris or Marika, they're more the
Genetic disorders. Yes.
Yeah.
So I think if the genetic disorder can be diagnosed, Elna, can you maybe unmute Chris, please? There you go. Chris, I don't know if you can see that question. It's in the chat box. It's asking, which lab can we send samples for genetic disorder testing?
So essentially you have, it's a bit different in the private and the public sector. In the private sector, you can send a sample or you can consult any of the pathology labs. They all have geneticists appointed now, and they will then send the sample overseas for genetic testing. There's also an alternative in South Africa called the UNGWE program. You can go to the website www.ungwe.org.za. And that is a collaborative research project where we aim to sequence patients with rare diseases. So if you're interested in that, you're welcome to contact us, and you're welcome to also to email me directly, chris.forster@northwestuniversity.ac.za.
Okay. Thank you, Chris. I also wanted to mention the UNGWE project now. So that is for undiagnosed patients. Chris. Sorry. That's for undiagnosed patients. So if the patient has gone through literally everything and doctor hopping and a diagnostic odyssey, and they still can't find any answers, and is suspected to be a genetic disorder, you can submit those patients to the NWE program, and in the program, they do as much as they can to get a diagnosis, including whole genome and exome sequencing. Sorry, Chris, did I interrupt you there? I couldn't hear you very well.
No, you actually summarized it quite well. Maybe just to emphasize again that, if you suspect a metabolic disease, so multisystemic involvement, typically we're looking at neurological, hepatic, gastrointestinal, dermatological, and then also symptoms that is intermittent, triggered by something, or progressively deteriorating. You should really start off with metabolic testing. It's just, at this stage at least, a faster and a more effective way of getting to a diagnosis. That will require genetic confirmation. On the other hand, if you are of the opinion that it's not metabolic, then genetic would be the starting point. And even if you do make a metabolic diagnosis there, you would still need metabolic confirmation. And also just a caveat is that you can, of course, also miss a treatable metabolic disease using a genetic approach. So it's not a replacement for metabolic testing, but in some patients it is justified.
Thank you. I don't see any other questions. We are over time quite dramatically, which is a good thing. This was one of the best attended lectures that we ever had. We had 72 people attending. Thank you very much, Brenda. I think that was brilliantly done. Oh, okay. Sorry, there's another comment quickly from Philip Snyman saying for genetic disorders, you can also use the Face2Gene app to get a few possible answers. Thank you very much. I know that's quite broadly used by the pediatricians as well. Face2Gene, that is the app. Yes, so thank you, Brenda, for a brilliant presentation and a brilliant overview. I just wanted to add for a last thing that for the African people attending, we already do newborn screening for African patients. So even if you are, we have different laboratories working with us, pathology laboratories throughout Africa, and you can actually already send samples to us for newborn screening through all of these networks that we've already established. You'll see on the website that there's also an international newborn screening and a national. So the international is mostly for African patients. Yes, I think that's it. Thank you very much, Brenda. I really think it was a great presentation and great feedback and participation from the audience. And then just a final thank you to Pfizer again for sponsoring this. They had absolutely no input into the presentation. It was all from Brenda, but we want to thank them for their assistance to also promote the awareness of rare diseases in the country. Brenda, you can have the last word, and then you can all enjoy the evening and keep warm.
Okay, I just want to say thank you again for everybody who attended. Thank you also for the Africa, all the doctors from South Africa, and let's create this possibility for all babies to be screened. Thank you so much and enjoy the evening.